Right. So I'm probably preaching to the choir here, but suicide is an urgent public health problem as it's the second leading cause of death in those ages 10 to 34, as you can see up here in this database provided by the CDC. And it can actually be argued that these numbers are an underestimate because some deaths that get classified as unintentional injuries may actually be suicide deaths. Suicide takes more lives than any medical illness in these age groups, and this includes cancer and cardiovascular problems. So, non-fatal suicidal behavior or suicide attempts that do not end in death are even more common but harder to estimate because a lot of them go undisclosed. But our best guess is that for every suicide death, there's about 25 to 40 suicide attempts. These next few slides will present data from the National Youth Risk Behavior Survey, which was referenced in a few talks earlier today. So this is a nationally representative survey that's conducted every 2 years for high school students, so those in grades 9 through 12. And in the last time it was conducted in 2017, it surveyed more than 15,000 respondents from 125 schools. So this is an anonymous survey, and it's conducted both at private and public schools. So based on the 2017 data, you can see that in the past year, 17.2% of students reported seriously having considered attempting suicide over the last 12 months. This rate was statistically significantly higher in female students and also statistically significantly higher in white students compared to Black students. Now, when you look at these data across gender and race ethnicity, it's actually Hispanic females that have the highest reported rate. And I think this is particularly relevant for those practicing in Eastern Washington. That rate was 25%. So 1 in 4 Hispanic females will have seriously considered attempting suicide in the past year. This next slide shows you the percentage of high school students who endorsed having attempted suicide at least once in the past year. That percentage is lower, 7.4%. Again, higher for females compared to males, but this time higher for Black students compared to white students. This slide shows you the trend over time, and though it looks like it's stayed fairly stable, when you control for gender, race, ethnicity, and grade, there's actually been a slight decrease over time, so that's definitely encouraging. This next slide shows you the percentage of high school students who attempted suicide and then required medical care from a nurse or physician. As you can see, this percentage is even smaller, and 2.4% might not seem like a lot, but when you take into account that there are 15 million high school students in the US, this comes out to about 360,000 students per year. So that is a big number. And again, statistically significantly higher in female compared to male students and in Black compared to white students. This is the trend over time between 91 and 2017. And though it looks like it's increased a little bit, it's actually, the prevalence did not change. This map illustrates the suicide rates in the United States by state. As you can see, Washington is in that middle category. However, since these data were published, the rate has actually increased in Washington. So now it's in the 4th category. The most recent rate was 16 per 100,000. Suicide rates are increasing in all regions of Washington, and we don't know exactly why. Southwest Washington has the highest rate, with Eastern Washington only a little lower. And we do know that in rural communities, suicide rates tend to be higher, and there's several reasons for that. One, obviously, is lower access to specialized mental health care, increased rates of alcohol and drug abuse, and also increased rates of gun ownership, which is something that I'll talk to you more about. And then these are the newest statistics published by the American Foundation for Suicide Prevention for 2019, and you can see the most recent suicide death rate presented here. Now, speaking more about Washington specifically, these are data from the Washington Youth Survey from last year. This survey asks those in 8th, 10th, and 12th grade anonymously about a variety of risk behaviors, and the ones pertaining to suicide are presented here. And if you remember from the National Youth Risk Behavior Survey, those reporting that they attempted suicide in the past year in Washington is actually higher than the national average. This slide over here shows you the suicide rates by gender and racial ethnic group. And I have here the data for young adults because the data for those under 18 is not as readily available, but the trends are very similar. So you'll note that the highest suicide death rate is in American Indian or Alaskan Native males, followed by Caucasian males. And so just, you all probably know this, but female students are more likely to attempt suicide, but males are more likely to die by suicide, and I'll tell you why in a moment if you don't know. Okay, so this graph is a trajectory of suicide across age, and as you'll notice, it increases sharply around age 13. What is going on at that time that could help account for this? Puberty, right? Transition to high school. This is not coincidentally also the time that depression rates start to increase starkly. Why did I spend time talking to you about non-lethal suicide attempts? And let me preface this with a lot of times parents and sometimes even medical providers will say, oh, well, what they did wasn't really a big deal because it didn't result in an injury or it wasn't lethal. They were doing it for attention, let's say. No ideas? Absolutely. So, mhm. Absolutely. So every suicide attempt has the potential to lead to death, whether by accident or by medical complications, even if there was ambivalent intent. And there's research that those who attempt suicide once are much more likely to attempt a second time, and each subsequent attempt tends to be of higher lethality. So really it is a risk marker, as you said. So what are the most common methods of suicide death in adolescents and young adults? What's your guess for those that are under 14 and under? Drug overdose, okay. Any other guesses? Yep, you are right. So suffocation, which includes hanging, closely followed by firearms. Why do you think this might be the most common method of suicide death in this age group? Something that is present in every household, right? There might be a rope or a belt or a scarf or an extension cord. And then also suffocation is one of the methods that has this shortest window for intervention. When someone has stopped breathing, really there's very little time to intervene. How about in the older age group, 15 to 24? Firearms, you got it. Oh, and a close second being suffocation. So just to get us thinking about the kind of teen that might present with risk factors for suicidality, I've included a case example. So Katarina is a 15-year-old girl. She has a history of depression and anxiety and is coming to a medical appointment. You, the medical provider, notice some cuts on her arm, and when you ask her about it, she tells you that she self-harms a couple of times a week when she feels overwhelmed by school, her parents, or her peers, but really it's no big deal. Her mother tells you that she recently discovered that Katarina was spending time with an older boy and that the two are regularly smoking weed together and also drinking from time to time. And during her visit, she complains to you that school is stressful, she gets verbally bullied, and one of her peers recently died by overdose. What are the risk factors? And there's no mention of suicidality here, but what risk factors? I'm sorry? Absolutely. Yep, so that's something you'd want to ask about, assess for. What are some of the other ones that stand out? Right, so there's substance use abuse.
Self-harm, depression, anxiety.
Yep, psychopathology, self-harm, exposure to suicide, being bullied. Absolutely, so we hit most of them. But gender, again, girls are more likely to attempt, boys are more likely to die by suicide, age, increasing age throughout the teenage years, psychopathology, depression, anxiety, hopelessness, prior suicidality, either ideation or behavior, exposure to suicide. Now, this is a really interesting one because it doesn't need to be someone that you know well, or is even a real person. So if all of you remember the 13 Reasons Why phenomenon / debacle, rates of suicide attempts and ED visits sharply increased after the show was released. So it doesn't need to be a real person for it to affect you. Abuse, neglect, substance use, bullying, non-heterosexual orientation. Why is that one a risk factor? Mm-hmm. So isolation, not feeling supported by others, bullying, all of those. Mm-hmm. Mm-hmm. So, got it. So some of it is self-inflicted isolation because it hasn't been disclosed. Absolutely. Absolutely. What do you notice about these risk factors? Are they unique to suicide? No, they predict risk for a lot of other things. So it just goes to show that there is multifinality in these types of things. Here I've divided the risk factors by more distal chronic risk factors versus more proximal, more closely related in time risk factors. I'll just highlight a few. The first one is in the proximal risk factor category, accessible means. And I'm going to keep emphasizing that one because this is one where we can most easily and effectively intervene. Suicide in the social milieu. This includes the suicide of famous people you don't know. And then just to clarify, the talking about suicide, this doesn't mean that if you talk to teens about suicide, this increases their risk. It means that teens that are disclosing suicidality ideation plans are at increased risk. Okay. And I just want to spend a moment talking about the difference between suicide and non-suicidal self-injury. So obviously, the main difference between the two is intent. With suicide, the intent is to die, whereas with non-suicidal self-injury, it's usually an attempt to cope, a coping skill. And sometimes it's even used in order to avoid suicidal behavior. What are some of the other differences between the two, based on your experience? Sorry, I definitely cannot hear you. Mm-hmm. Yeah, so the methods and the lethality tend to differ between the two. Right, so with suicide, it's usually one method that's used, and you saw what the most common ones are. And with NSSI, multiple methods are more common, with cutting being the most common one. People usually are hopeless and feel no better after suicidal behavior, whereas with non-suicidal self-injury, there is relief experienced after the fact, after the act, which is actually what reinforces the behavior and makes it harder to change. And then finally, there's varying lethality with suicide attempts, whereas with NSSI, it's typically low lethality. It goes undisclosed and medical attention is not needed. However, despite the fact that it's considered distinct phenomena by some, there's actually a very strong association between the two. So first of all, suicidality puts you at risk for engaging in non-suicidal self-injury, but more importantly, in my opinion, is that having engaged in non-suicidal self-injury is actually then a risk factor for future suicide attempts. So the more often you engage in an suicide, the longer you've engaged in the behavior and the more methods you use, that predicts more future suicide attempts and higher lethality of those attempts. So if you ever see a teen that's self-harming but denies suicidality, it's still very, very important to keep tracking that over time, because chances are suicidality will pop up in the future.
Do you know what percentage?
It varies based on study, so if you're looking on population or people that are actually presenting to mental health care, but it actually goes up as high as 80%. So it'll vary. So now that we've discussed the scope of the problem, let's turn to suicide prevention efforts. September 10th is National Suicide Prevention Day, so this talk comes at a timely time. All right, so let's start with primary prevention. What is primary prevention? So it's intervening, providing an intervention before a disease or injury has actually occurred. So some examples here on the slide: providing vaccinations, immunizations, laws mandating the use of seatbelts, and then education on healthy habits like exercising, eating well, and not smoking. And then secondary prevention, what is that? So it's catching things early in the process so you can stop their progression, or at least slow the progression. All right, and some examples are presented up here. Now, I just wanted to highlight that Washington is kind of ahead of its time in a lot of ways. In 1995, it created its first youth suicide prevention plan with very specific recommendations, and this led to state funding being set aside for suicide prevention, public awareness campaigns, and something that affects everyone sitting in this room, which is a bill that was passed which requires health professionals to get training in suicide assessment, management, and treatment. So these are the goals presented up here. All right, so primary prevention as it applies to suicide. So educational campaigns on suicide and on restricting access to lethal means. And then there's a video that I want to show you. This one is not from Washington, it's from Utah, but I think it's a good example.
I'm gonna be a little impulsive.
Sometimes I'm gonna be a lot impulsive.
I mean, I'm a teenager.
Like when I went through that really bad breakup.
To you, it may have been no big deal.
But to me, it was my whole world.
It was my whole life.
Remember when I got arrested?
I actually thought that I would never be able to show my face in school again.
And when that rumor about me started spreading,
All over social media.
I thought it would never end.
Like, I thought the only solution was for me to end.
Not to freak you out or anything,
But the leading cause of death in Utah,
For teens,
It's suicide.
And nearly half of those suicides are from firearms.
and sorry, but they're usually yours.
So help us out here.
because we may be impulsive, but
We wanna live.
almost all the time.
But in case there are times that we forget, keep your guns and ammo locked up safely.
Keep your guns and ammo locked up safely.
Locked up safely.
Because doing this little thing,
Can make a big difference.
All right, and there are other PSAs like this that exist, but I think this one is well done. All right, so some other primary prevention strategies that have been used, as you were noting, the medication packaging and dispensing. Some medications are packaged individually, so it takes some time to get the pills out, putting time between the urge and the ability to overdose. Some medications are dispensed in smaller quantities. We'll also talk about using lock boxes to lock up medications. Newer cars have safety features, including those that prevent suffocation from carbon monoxide. And then there are media guidelines in terms of reporting on suicide. I frequently get asked about this, so I've included this up here. I'm not going to read through all of these, but I just want to highlight a couple, which is wording matters. And the amount of information you provide also matters if you look at the top. So this is interesting stuff to read through on your own time. All right, suicide primary prevention efforts have also been focused within schools, and there are these specific programs that exist. I'm not going to spend any time talking about them right now. If you have questions, you can ask me afterwards. And then primary prevention also focuses on increasing protective factors, building resilience, social support, and positive experiences for youth. All right, secondary prevention, which is where I think a lot of medical providers come into play, have focused on these gatekeeper training programs. So these are individuals that tend to interact with youth more often. So it includes health providers, but also teachers, police officers, and alternative people in some communities like elders. And here the goal is really to increase knowledge of suicide, the risk factors, and help people ask more about suicide, because there's definitely some reluctance. And the main recommendation here is that you screen, intervene briefly if possible, and then refer to evidence-based care. Now, I know this is the piece that's hardest, especially in under-resourced and rural communities. So I'll talk a little bit about that later. But these are some of the measures that exist. The PHQ-9 is used in a lot of healthcare systems already, so it's one that a lot of people probably already use. For those of you that are not familiar with it, it's these 9 items, with item 9 specifically asking about suicidal ideation or thoughts of self-harm. So if a teen indicates any non-zero answer, you would follow up with additional questions to determine whether it's suicidal ideation versus just self-harm thoughts, although both, as hopefully I've convinced you, would be of concern. And then following up with whether they've ever acted or recently acted on these thoughts or have any intent to act on these thoughts. You might be less familiar with these ask questions. These are more suicide specific, as you can see. I won't read through them. But the ask tool also comes with specific guidelines for what to do if a teen endorses suicidality on these questions. So what are the effective interventions or treatment components for suicidality that you all are familiar with?
Counseling.
Counseling regarding what? Or do you mean therapy?
Yes.
Yes, psychotherapy. What kinds of psychotherapy? DBT. Yeah. Linkage to care. Yep, absolutely. So 2 that I think are readily and easily transportable into medical practice are restricting access to lethal means and safety planning. And one of the components of safety planning is restricting access to lethal means. But basically, you all are probably familiar with safety planning, but it's coming up in advance with a set of skills that you'll use in a time of high distress or increased suicidality. And it also includes thinking about which people you'll reach out to for support. And this could definitely include parents, but does not always include parents. And then enhancing motivation to attend follow-up care. Now, really important here, safety planning is not a no suicide contract. No suicide contracts do not work. Please do not use them. All right, what are the effective psychotherapies? There's a group of CBT approaches that are specific to suicide, and DBT is one of them, as someone mentioned already. There's something called the Collaborative Assessment and Management of Suicidality, which also has data evidence for youth. And then finally, these more psychodynamically oriented treatments, mentalization-based therapy and transference-focused therapy. I also want to make you aware of a set of ED interventions. Obviously, in the ED, your goals are different than in longer-term counseling. So here you aim to conduct a risk assessment in order to determine appropriate triage, hopefully provide a brief intervention that helps at least mitigate immediate risk, and then help with care linkage. So why do you think it's important to have interventions for this setting? And why am I talking to you about it? Exactly. Yes. So initial point of contact. Mm-hmm. Yep, absolutely. So there's a variety of ways that they can get to the emergency department. Schools frequently send kids to the emergency department for liability reasons. The police is another route. And also youth who have made a suicide attempt that resulted in an injury or necessary medical care will also frequently end up here. Why am I presenting it to you providers that likely work more often in the outpatient world? Well, first of all, they're coming to you, and second of all, I'm hoping these interventions will be transported into the outpatient world because they're brief and they have been shown to have, effectiveness in certain ways. These are the specific interventions. I'm not going to spend very much time talking about them. I just want you to know that they're brief, and their main goal is to create a positive experience with mental health treatment to mitigate immediate risk, and then to help people get linked to that appropriate follow-up care. So I'm just going to click through this, but I'm happy to answer questions about this afterwards. Just want to point out there was one study done on the family intervention for suicide prevention, one of those ED interventions that showed that those that got the FISP, 92% of those kids got linked to follow-up care and attended treatment. So this is very encouraging. Research is constantly being done in the field of youth suicide prevention. And this is one study I want to highlight because it's the first RCT of a stepped care intervention. It's a collaborative effort between UCLA and Kaiser Permanente in Oregon. And we're specifically testing this intervention that matches, or this model that matches level of intervention to suicide risk. So it's a more efficient use of limited resources. And then youth are able to move between levels. So if someone starts at a low level, but then it turns out that they need more, they are able to move up. So this is an ongoing trial. We'll let you know what the results are when they come out, but stepped care is something that's been used very effectively in other areas of medicine. So hopefully we'll be able to use it for suicide prevention as well. Something else that is another effort that is being made is to create these crisis consultation clinics. These are clinics that are meant to provide brief intervention, 2 to 4 sessions for youth with suicidality so that they can stabilize, so fewer of them will show up in the ED or on inpatient units. And so more youth can then be linked to appropriate outpatient care. We have one of these clinics currently being tested at Seattle Children's Hospital, so we'll keep you posted. So far, we've had about 30 kids seen in our clinic and with pretty good results. So what can medical providers do in terms of suicide prevention? Education. Mm-hmm. Education on what? What specific aspects? Mm-hmm. 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 So establishing that connection, providing resources, providing education to parents. Absolutely. Well, first of all of you will obviously be doing your suicide prevention training as mandated. And then my urge or my hope is that you will screen all patients that come through your practice. Just by a show of hands, how many of you routinely screen all the adolescents that are seen in your practice? So quite a few people, but not everyone. How many of you have a standardized protocol for suicide screening and management within your clinic? So fewer hands up. So really, it's important to screen all patients, but before we can get to that step, you really need to have a protocol in place, because if you screen and someone screens positive and you have no idea what to do, then that's not so helpful. Be able to recognize these risk factors, warning signs, although suicide is not perfectly predictable. Engage in safety planning and counseling around restricting access to lethal means. Really, if this is the only thing you do, you'll already make such a big difference, because a lot of suicide attempts are more impulsive. They're not pre-planned or thought out, and really what makes a difference is the availability of means. And you know, sometimes parents will tell you, or caregivers will say, well, if my youth really wants to hurt him or herself, they will find a way. You know, there's so many different things you can use just in a regular household. And while that may be true, creating more barriers and time between the urge to harm yourself and the ability to act on it provides time for the person to either change their mind or for something to intervene. So for the parent or someone else to intervene in the process. So really just creating as many barriers between the urge and the means. And medication safe storage is a big one. Unfortunately, a lot of the times the medications that are used are over-the-counter medications. And so counseling parents around that. We've also had teens overdose on PET medications, which is one that medical providers don't always think to counsel around, and parents don't think of either. So really, there's no reason to have a large amount of over-the-counter medications at home. There's no reason to have a bottle of 200 pills of ibuprofen. So just smaller packages, lock them up, especially during times of increased risk. Help make that connection, identify what the youth and family's strengths are, and help them build on that if possible. Provide resources, and I have some on the next slide for you. And then finally, refer to evidence-based care. Now, I know, as I already mentioned, this is particularly hard in rural, under-resourced communities, and so requires a more systemic change, but there are strides being made around this. So first of all, integrated behavioral health care is something that is becoming more prevalent. So hopefully all of you will have mental health co-located or integrated within your practices. Telehealth is something that's also increasing. Seattle Children's Hospital in particular is accrediting more providers, and more providers are able to see youth this way. Schools can be a resource. There's typically a mental health provider within schools. And then finally, there are consult lines. So if you really are the only person that can follow this youth, there are people that you can consult with and get some guidance from. And so these are just some of the resources that I wanted to highlight. You may be familiar with some or all of them. The top three have specific resources for providers, and then all of them have resources for youth and their families. All right, any questions? And I can go back to this slide. Yes, absolutely. High correlation with the academic year. So we see a spike within maybe like a month of the beginning of the academic year, and then at the end of the academic year. Summers tend to be calmer. Yep, so those are higher risk times, one of which we're entering right now. Yes. Mm-hmm. 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 Through education and sharing the data with them. I don't know, does anyone else have ideas? How can we increase the awareness that non-suicidal self-injury should be taken seriously? Manipulative. Yeah. Thank you. Yeah, thank you.
Any other questions, comments, concerns?
Yeah. All right, well, I just want to leave you with this. Although suicide is not always predictable, it is often preventable. And everyone in this room, mental health providers, play a very key role in suicide prevention. So I will leave you with that. Thank you.